Conversations in Frailty, the podcast for Derbyshire clinicians.
Hello, and lovely to have you joining me for episode 14. Dizziness was a topic I'd been planning to cover soon. I think for most clinicians working with frail patients, it's safe to say it can be a challenging presentation to unpick and manage. So I was delighted when Louise and Katie of the Deprescribing podcast, which is definitely one to listen back to if you haven't had the chance yet, recommended Dr. Gkiousias, an audiovestibular specialist doctor, as someone enthusiastic and interesting to discuss this with. Perhaps because he's a specialist in the area, he's mentioned a few terms that I've taken the liberty of adding in a few moments where I'll briefly give you more detail on a test he mentions and signpost you to where to watch a good YouTube video. A lot of these tests are really better seen than simply described, and we haven't got time to cover them all, or you'd be sitting listening for far too long. So on with the podcast. What do we cover? A bit about normal balance, how it works, and then the impact of ageing on this. We look at some presentations of both acute and chronic dizziness. Listen out for some tips on some good history questions he uses and how to adapt examination techniques in these patients. We chat about drugs commonly prescribed and finally get a little bit of an insight into what actually happens in an audiovestibular clinic. Enjoy. So this afternoon I'm delighted to have with me a doctor came highly recommended by a couple of my previous interviewees, Dr. Vasileios Gkiousias. And introduce yourself with the listeners.
Hello, Sarah, and thank you so much for inviting me to take part in the podcast. So I'm a ST5 registrar in audiovestibular medicine, which is a very niche specialty not many clinicians know about. No? So essentially what we do, we work closely in the head and neck department with ENT, but our scope of practice is quite different to ENT. So we deal with the more medical aspects of hearing and balance, and we cover pretty much 0 to 100 in terms of ages, so we see a little bit of everything. And I have to say things are quite different in the pediatric and the adult world, so you don't really treat them the same way in some sense. I think it's worthwhile knowing about us and what services we offer in our scope of practice, which will hopefully help with referrals in the future as well.
Great. And, balance, dizziness problems, we see it all the time when we're sort of dealing with the frail elderly population, so really relevant.
So I'd say it's often a very neglected entity, and partially to blame probably the amount of things you have to cram into your undergraduate medical school training. Balance is one of those that just gets neglected or very briefly touched upon, and you have maybe a few lectures on it. So a lot of people actually end up being quite apprehensive about it and very scared about it. But as you might have come across before, it's very, very common. So about 30% of over 65s will have an element of a balance problem, and then that becomes as high as 50% in the over 80s. So it is very, very pertinent in the clinics that we see.
And it's unpleasant, and it puts them at falls risk, which is a big worry for us.
Yeah, definitely. The other thing with all of the balance problems and conditions is that gradually, without realizing, patients become quite reserved and they retract from social activities. They prefer to not leave the house. They develop what we call movement avoidance and fear of falling, and rightfully so, especially if they've had near misses or falls in the past. So chronically, they tend to sort of isolate themselves, and then that on its own comes with other problems such as an impact on their conditioning. They lose muscle strength. They don't go out for walks like they used to before. And mental health gets affected as well, because essentially you're stuck within four walls, not seeing many people, and that on its own can cause other problems. So it is quite a pertinent problem.
Yeah, and even cognitively, I suppose now they're saying that, social isolation, dementia risk, it's huge, isn't it, actually, the spiral they can end up in. So before we get on to dizziness itself, can you just talk us through briefly a little bit about just remind us how normal balance works, and then sort of how each system is affected by that ageing process?
So a nice little spiel I like to give to all of my patients in clinic, whether they hear me or not, is basically understanding that balance is a bit like dealing with a puzzle. You've got lots of pieces on a big table. Some pieces you've dropped off the table, you'll never get them back. The pieces that you do have on the table, you try to arrange in a way that makes sense. So I think as a starting point, it's worthwhile setting expectations and telling them that ideally we would find an answer, but a lot of the times we don't find a succinct answer and a clear answer for what's going on. And we try to work with what we've got. The three main systems for balance integration at any age are vision. So about 80% of the information we balance on comes from our eyes. So I always say if you've neglected your eye health, and usually our elderly patients tend to be a little bit better than our younger ones in this regard, just to arrange an eye check, which can be done again in the community by an optician coming as a home visit and doing like a basic assessment to make sure we're not missing grossly major things. Cataracts are quite common in that age group. And we have found before that surgically correcting or even with glasses actually can make a huge difference to symptoms and improve your balance as well. Varifocals is another one that we tend to say, please try and avoid if you can. I know practically a lot of people like them, but actually, especially with things like going down steps, you risk falling. So we always say try to optimize your prescriptions if you can.
My husband's just got varifocals and he's saying the very same thing.
Yeah.
Yeah.
Somatosensory is the next system. So about 15% of the information we use to balance comes from our joints. And it all starts from, can I actually sense what I'm stepping on when I walk? Again, the main culprit in this age group would be things like peripheral neuropathy. Or vascular causes. By far and large, diabetes, I would say, is probably the one that causes most of the detriment. So essentially, as I like to say to the patients, imagine having a huge building and the foundation is a little bit iffy and you're not quite sure what you're stepping on. So every time it feels a bit like you're stepping on cotton wool. So your balance will not be as robust as it used to be before. And if you add to that things like joint problems, wear and tear with osteoarthritis, joint replacements as well, you just lose that natural feedback that you used to have once.
Yeah.
So that's quite an important system. And thirdly, which is the smallest percentage of them all, about 5% comes from your vestibular system. But for those that have been affected by vestibular problems, you know how important and debilitating it can be. So it's all coming from the inner ear, essentially, which also deals with hearing and balance as well.
Yeah, I'm surprised how little, the small percentage the vestibular carries, actually. That's interesting. And so each of those, as you said, as you're getting older, goes down. Vestibular processing, does that get affected very much by age? Or?
Yes, so there's a concept which is very recent in literature and has been encountered even in populations with traumatic brain injury, but we know that it happens in neurodegenerative processes like Parkinson's disease, Alzheimer's, dementia as well. So you develop what we call vestibular agnosia. So essentially, the processing in the brain is not in sync with what's happening at the level of your balance system, and it might be the case that your balance system is actually operating okay, but the processing from that is a bit haphazard. So there's almost a little bit of a lag between your systems and your integration. And I guess practically what that might translate for most people in clinical practice is when you try to take a history on balance and dizziness, you will find that you ask the same questions in a different way and people give you different answers. There's no consistency across the board. You go back and back again, and it just gets very, very tricky. But it's often to do with the fact that you're not cognizant of what's going on within your own body and your own balance, essentially.
So will those people be people who feel dizzy but don't tend to fall, or could they still be people who actually...
You could be feeling dizzy, but not in the traditional sense. So again, back to medical school teachings, things like BPPV or typical presentation would be I'm rolling around in bed and I feel as if I'm going on a merry-go-round. But in the elderly, that might be perceived as I feel like I'm falling off a cliff sometimes. Some people might not even express that and might say, oh, I keep on waking up in the middle of the night and I'm not sure why. Which is very, very difficult to extrapolate and link to BPPV per se. But it's worthwhile thinking that your typical history taking might need to be tailored accordingly because people don't volunteer the same information.
Okay. Well, that takes us neatly on to, I wanted to talk in the next section really of the podcast about going out and assessing a frail, dizzy patient, whether we've been called to a home visit or in a care home or whatever setting. Rather than do cases where we need to sort of remember lots of details, I just wanted to take sort of case scenarios. So the first one was we get called out to somebody who has an acute new onset dizziness, and it's really just saying red flags, what should we be looking out for things we don't want to miss?
I think, as with most things, anything that's new onset and severe should always raise some sort of alarm from the usual patient's baseline. New onset neurology, headaches, vomiting, that sort of thing is usually more of a red flag. What also can be useful at the bedside, which I guess you could implement in more frail settings as well, is what we call a HINTS examination. So you can do a combination of three things essentially, one being the head impulse testing, one being checking for nystagmus, and one checking for skew deviation. And then depending on the results you get, that can sort of like guide you towards an acute stroke-like event versus something more vestibular and more balanced.
So HINTS is an acronym which stands for Head Impulse, Nystagmus and Test of Skew. This is a test that can be used in patients with acute but persistent vertigo that's been going on for hours or days, who have nystagmus but no abnormal neurological findings. It's used to help work out, is the cause peripheral, which is probably most commonly a viral inflammation of the vestibular nerve, vestibular neuronitis, or is it the rarer but more worrying central cause from a posterior circulation stroke? Occasionally, these patients with a stroke don't have any other easy neurological findings to pick up to help us. So there's a great explanation of this if you want to look into this. If you put HINTS exam make a medic into YouTube, and there's also links on that to videos of actual patients to watch. It may or may not be a test that you feel you've got the confidence to use, but I think it's certainly worth understanding a little bit about how it works and the importance of trying to work out whether somebody at least needs to find, is there a possible central cause going on here?
For our listeners as well, so a lot of people within the audiovestibular medicine world advocate a HINTS plus exam just as an added bonus. So the plus bit would be a hearing test. So if the hearing test is abnormal, then that points you more towards a vascular event than a vestibular event.
Okay, but not easy to do acutely then for us,
obviously.
No.
Yeah.
Challenging. Okay. And what about the more chronic dizzy patient, the patient who we see in the care home who has been dizzy on and off for years? What are the red flags and the common diagnoses you might see there?
I think with the chronic dizzy ones, again, a change from the usual baseline. I appreciate it's not pleasant to be having chronic dizziness, but has that changed recently? Have the symptoms been progressively been getting worse? So are we thinking alongside the lines of, is there a tumor that's perhaps growing and causing symptoms progressively that weren't there before? Again, new neurology, new features that they didn't have before. It's always worthwhile thinking about headachy type presentations as well, and thinking about have they had a history of migraines, because it's often neglected, and people will tell you, oh, I used to get horrible migraines, and so the adage goes that once a migrainer, always a migrainer. So is this a type of migraine that's just unrelenting and has stayed there for years and they just get less frequent episodes? By far and large, we tend to see this sort of like early teenage years, pregnancies for women, and then menopause again for women, but also in men we do get it quite frequently. But yeah, if they've had something in the past that's vestibular sounding, could it be the case that it's sort of like flaring up again?
Okay. So at this point, given we were thinking about chronic dizziness, I wanted to add a helpful explanation from Vasileios about what's going on in BPPV, benign paroxysmal positional vertigo, given it's one of the common causes we see in our frail patients.
So BPPV, we're looking into crystals in the inner ear, which is the third part of the ear that we all have. And crystals should be neatly stuck on a membrane and move with the head and telling you what you're doing when you accelerate and decelerate, or if you're going up and down. So for example, if you use a lift, that's what gets picked up by the otolith organs. We know that with age, we know that other factors such as head injuries, other vestibular pathologies like migraines, Meniere's disease as well, can make people more prone to getting BPPV. It's very, very common in the over 80s. And essentially, it's all to do with crystals shifting from the otolith organ, where they should be snugly stuck on a membrane, and going into one of the semicircular canals, which regulates angular head, sort of like movement and detection of movement. And then when the head assumes that specific position that the crystals are in, it gets signal to think that it's moving, and that's when we get the vertigo, and the brain is trying to correct that by flicking the eyes the opposite way. So that's the type of nystagmus you see on the bedside. It's been there for many, many years. It is quite a complex entity, and you can get lots of different parts of your vestibular system and semicircular canals involved, which complicates the picture. But it's equally quite satisfying and straightforward if you identify it to fix it.
So now back to the main podcast, and we go into some tips around history taking and then a bit about adapting our examinations. And when you see one of these patients, particularly the sort of chronically dizzy patients, do you have a way of trying to put them into different categories from their history, just to help the listeners sort of think about how they structure it?
I think the first important bit is to try and get out of them what they mean by dizziness. As you might know, if you ask 10 different people on the street, they would give you 10 different answers. One nice little tip I've got for the listeners is try to ask them to describe their dizziness without being allowed to use the word dizzy. So play a little game with them and say, you're not allowed to use dizzy. Tell me whatever you want, whatever obscure and absurd thing you have in mind. Just let me know about that versus saying I'm dizzy. Because it could be a lot of different body systems, so not just vestibular, cardiovascular, neurological. Orthostatic hypotension is quite a common clinical entity in that age group, and it comes more with lightheadedness. But some people, again, in view of that version of agnosia, might not be completely sure how to describe it best. So the first starting point is getting the definitions about dizziness clear, and then asking about balance in general. So how are you when you walk? Can you manage a straight line without veering to the sides, bumping into people you walk alongside, bumping into doors? Have you become more clumsy in the recent years? Again, somebody that's been clumsy throughout their whole lives, I'm less worried about versus somebody that's suddenly becoming a little bit more ataxic and clumsy and dropping things and bumping into objects. So I think that's always a good starting point, and then try to maybe phrase the same questions in a different manner when you revisit the history, which can be quite tricky. Collateral history is super, super important. Oftentimes, patients can adopt a bit of a stoic approach and not tell you what's actually happening, and then you can see the relative in the back nodding their heads. So it's always useful if you get these patients to try and have somebody that knows them with, either a care or a partner or a family member. That's often quite useful and helps you sort of like fill in the gaps from the history.
That's really helpful, actually, because I think we always know when they're having blackouts that collateral history is vital, but actually I would say that's less commonly perceived as important, but I can see that. That's really
and
helpful.
One last thing that's really, really important is to try and identify if there is some sort of memory impairment / dementia process underlying the symptoms, because we know for a fact that it can actually make you quite wobbly. And it's often the first time that people might flag it up in clinic, and people haven't actually thought about memory impairment linking with balance. So I'm guessing it might be more common as a diagnosis and more thought of as a diagnosis in this population, but it's always worthwhile exploring and asking at least a screening memory assessment, and then refer along to the memory clinic if they need that, because that can be quite significant as well.
Yeah. Okay, that's great. So on to a few tips around examination, I suppose. Some of the examinations we might think are going to be very challenging if we're seeing a frail patient. So typical cardiovascular checks and checking for nystagmus, those are straightforward.
Yeah.
The Dix-Hallpike test. So final interlude about the Dix-Hallpike test. So this is a really useful test to try to confirm a diagnosis of BPPV. The HINTS test is what we should be doing with a new acute persistent vertigo. The Dix-Hallpike test is when somebody has paroxysmal vertigo, so they have a brief episode of maybe less than a minute when they move their head position, and in between episodes it's normal. The Dix-Hallpike test is very useful then. And if it's positive, it can then be extended into something called the Epley manoeuvre, which is actually a curative treatment. Now, the details of the test are probably best watched on I would recommend the Geeky Medics website for this. They talk through it and there's a helpful video. It's not an easy test to perform in a frail patient, but Vas does have a couple of tips of ways to adapt it. So if you can possibly manage it, it is a really useful bedside test we can do.
Routinely in clinic, I would screen everybody with a Dix whole pike if possible, only because it can make a huge difference having undiagnosed BPPV and having chronic dizziness. Nobody really knows what's going on and nobody has looked into it. And it's such a specific positional test that you have to do with the patient. Some tips as well include what sort of bed are you having? Are you able to recline further backwards so they don't have to extend their neck over and beyond the bed? Can use pillows as well underneath the shoulders or underneath the waist to sort of like try and do the flexion at the lower point that doesn't burden the cervical spine. So there's a few versions of that, and the contraindications are there, but they're not hugely detrimental to the point where we see people in clinic often and we say, oh, we're not doing a maneuver. More often than not, I'd say we would do the maneuver and try to modify it a little bit based on the patient, what they can do versus not doing it.
And that test is then the one that can confirm that diagnosis for you.
I think the other interesting bit about BPPV is it's been branded the osteoporosis of the inner ear. That's why it's very, very common in the older female patient as well. There's a cumulative effect with estrogen levels being depleted as well. So we know that women tend to be more prone to developing BPPV, and that's why after repositioning maneuver, which should be ideally the first point of management and treatment, we tend to put them on a high-strength vitamin D supplement, which arguably, again, I say, in the UK, by virtue of having minimal sunlight, you're probably better off being on a vitamin D supplement throughout the year. But even more so with BPPV is very, very useful, only because the crystals are made of calcium carbonate, which is metabolized through vitamin D. So the theory says that if you optimize your vitamin D levels, you're less prone to having recurrent episodes of BPPV. And it's a very cheap intervention, so.
And we so often want our frail elderly patients to be on anyway. I feel like any dizzy patient, if in doubt, let's try the vitamin D. Potentially, yeah. So management options. I guess we always want to talk about medication as one of them, although one of many. Or perhaps I often mention deprescribing these podcasts, and I'd be interested in your opinion on. We see quite a lot of patients in care homes who have been on something like beta histine for years, and any thoughts with the listeners on that?
So I think across the board as a specialty, audiovestibular medicine, physicians tend to favor deprescribing and try to optimize things with lifestyle modifications. Again, as with BPPV, you can get specific maneuvers and things, but I guess for certain conditions like Meniere's disease, you might rely on something like beta histine. Again, the consensus is that you should be supporting the patients in an acute phase of a vestibular or otherwise vertiginous or nauseating episode with something for up to 5 days or so until they get they take the edge off, and then you should slowly taper them down and not leave them on anything for too long. Interestingly, beta histine, although it's not an anticholinergic medication per se, studies have shown that in the long term can be associated with anticholinergic burden, which can increase your risk of falling and also interact with other medications you take. The one we definitely try to not leave them on for too long would be prochlorperazine, by virtue of it giving extrapyramidal side effects. Actually, funnily enough, we did have a patient in clinic that had been on prochlorperazine for a good 9 years, and then they had become Parkinsonian-like almost. And after the withdrawal of that, the balance went back to normal. So it's important to think about these things, because I know sometimes we all want to do the best for our patients, but we start something and then we never really check, and that's, I think, where it's really important to link in with your local teams and trying to do medicines reconciliation and deprescribe if you can.
And if you were prescribing acutely in the more elderly patients, are there any drugs they particularly favour? Obviously, we've got to take account of comorbidities and other drugs, but...
I mean, I'd say probably a combination of either beta histine and or cinnarizine, and then bacastem is quite good. So bacastem we tend to like because you can just pop on the inside of your cheek when you're feeling very nauseated, so you don't end up vomiting, and you're not quite sure what bit got absorbed. but usually we try to avoid it if we can. And then obviously migraine has got an array of different medications we can prescribe. But again, the starting point with migraines again would be a stepwise approach where you start with lifestyle modifications, and by far and large, sleep and stress are the most important things for migraine management. So you find a lot of people just simply changing their way of life, which I know sounds easier than actually is sometimes, can make a huge improvement to their migraine symptoms without any medications.
Great. And I guess we've also got to remember to just do a medication review in terms of if they're getting any postural drops that are contributing, making sure that we're looking at relevant drugs there. Fantastic. Well, just to finish, I thought it would be nice for us to know very briefly about your, where you work, Vasileios, the audiovestibular clinic. Just what sort of patients are you generally seeing there, and what sort of things are you doing with them?
So again, I'm currently in an adult rotation, so I'd say on average probably we're looking late 60s onwards, but we do get younger than that and significantly older than that as well. And I have to say some of our much older patients are often less complicated than our younger patients. So what we do, a comprehensive assessment of hearing and balance. Everybody gets a hearing test because, again, hearing on its own can be linked with reduced spatial awareness and missing out on socializing and ending up isolating yourself, which in turn leads, as we discussed, to becoming less and less fit and deconditioning and becoming isolated. Independently, hearing loss has found to have links with dementia. We're not sure about the causative part yet, and I think it's an ever-evolving field. But we always advocate if you've got a hearing loss, you should try to optimize that by hearing aids. And then oftentimes that helps with tinnitus as well, which is another thing we see in clinic quite a bit. Then we do a comprehensive examination and assessment, BPPV testing for everyone with the different maneuvers like the Dix hole pack and the head roll. And then we tend to investigate usually with things like blood tests, balance tests, and some sort of imaging, usually MRIs. On the balance test side, it can get quite complicated, but essentially we've got access to a very good array of neurophysiological tests and assessments to check the inner workings of the balance system and things that can diagnose, for example, vestibular hypofunction. And again, I like to say to my patients, if you think about yourself as a plane with two engines on the left and the right, if one engine has stopped working or is working less than the other, it sort of like pulls you with it. So you're not flying level and you tend to sort of like deviate and veer.
That can be one of the reasons they sort of
walking to the side. And I'd say if there ever is a doubt about that, it's always worthwhile pinging us a message or a referral and saying if we can assess them in clinic. Again, I appreciate with very frail patients it might be quite cumbersome to even get them in clinic, let alone get them tested. But we can always tailor that approach accordingly and see what we can get out of them. Of note, one of the things that's quite useful that we offer would be vestibular physiotherapy. Yeah. And then we work closely with very specialist physiotherapists that live and breathe balance. And they've been doing this for many, many years, very, very experienced. Some of them are doing chronic pain as well, which is quite relevant for all of our patients, and fatigue as well. And then that helps with sort of like trying to ameliorate any detriments from your vestibular hypofunction. But as I said, you hardly ever get just a single thing causing everything and explaining the whole picture. It's often on par with what we call multifactorial disequilibrium, with a lot of people dread as an entity. But I think that also highlights the importance of multidisciplinary collaboration and speaking to your colleagues and trying to optimize your healthcare provision as much as you can.
Yeah. And I mean that I feel like that comes back again and again in different topics I cover, because actually so many times in these frail elderly patients there isn't one diagnosis at the end of the day. There's a whole list, isn't there? Yeah. Well, thank you very much. I shall look forward to listening back to this myself a second time, and there'll be, I'm sure, lots of learning points for the listeners. So thank you ever so much for your time.
Thank you for having me, and I hope everybody enjoys this. Thank you.
So I'm sure you'll agree, loads of valuable learning material there, and I think that one might warrant more than one listen through. In terms of take-home points, I was reflecting that actually the way we take a history from a patient with dizziness can leave us feeling frustrated. But actually, Vas's suggestion, firstly, to maybe get them to describe it without using the dizzy word might be helpful. And secondly, having that concept that they may have developed vestibular agnosia, the idea that the vestibular system's still working, but the brain is losing its ability to perceive motion, and that can actually be very difficult for them to describe. That's really helpful for us to understand, I think. So, thanks once again for listening. Do keep sending in your suggestions of new topics. Please don't forget that this is just a conversation with one expert in the field. So if you're making individual clinical judgments, obviously refer to your local and national guidelines. And I look forward to having you listening in for our next episode.
Conversations in Frailty. Thanks for listening.